Hi, everyone. Thanks for coming today. We're just going to wait a few moments. We've just started the webinar and we're just going to wait a few moments for the participants to come through. Hope you're all having a pleasant morning and now afternoon because we've just clicked over. All right, starting to steady off, so I might get started. So hi, my name's James Petty and I'm a project officer at the Victorian Alcohol and Drug Association. Welcome to today's TriPeaks webinar. It's the first one we've had in a little while. TriPeaks is a collaboration between VADA, the Centre for Excellence in Child and Family Welfare, and the Victorian Healthcare Association. So I'd like to first start by acknowledging the traditional owners on the lands on which we're meeting. As we're online, those lands are very varied, but I'm coming to you from the lands of the Wurundjeri people of the Kulin Nation. I'd like to acknowledge their continued connection to land, sky and waters and pay my respect to their elders past, present and emerging, as well as extending that respect to any Indigenous people joining us today. Sovereignty of this land was never ceded. It always was and always will be Aboriginal land. So today's topic is brief intervention for substance use disorders, and we're very lucky to be joined by Dr. Erin Kelly from the Matilda Centre for Research in Mental Health, Mental Health and Substance Use at the University of Sydney. Dr. Kelly is a practicing clinical psychologist and research fellow at the Matilda Centre, where she leads a program focused on brief intervention for the prevention of substance use and mental illness. So let me assure everyone today that the presentation will be recorded and the slide pack will be made available afterwards. It'll take a few days for that recording to be to go live, but I'll notify everyone when that's available. We will have time for questions at the end of Dr. Kelly's presentation. Please submit your questions using the Q&A function at the bottom of your screen. It looks like two little chat boxes. The chat function will only be monitored for reports of technical difficulties. So again, please submit questions to the Q&A function. So with all that covered, I'll hand over to Dr. Kelly. Thanks very much.
Thanks, James, and hello, everybody. As James said, I'm from the Matilda Centre. So this is some of us. I think there's even more now, so you can try and find me for fun. And yeah, we're based at the University of Sydney. We've been around for a few years now, I think since 2018, and kind of across the spectrum, but a lot of the work that I do is in prevention, but I do double in treatment as well, being a clinical psychologist. So we've got a whole range of projects and you're welcome to check out our website to see what else we have going on. But today I'll be focusing on brief interventions for substance use, as James said. So I'll begin with kind of talking about brief interventions in general, and then a little bit more focusing in on what I do, which is more using the idea of brief intervention, but in a prevention format instead of a treatment format. But just a little bit of background before I jump into the brief interventions is just to map out that substance use is a problem in Australia. It's probably not a surprise to anybody, but this is the latest version of the National Drug Strategy Household Survey. And as you can see here, alcohol use is by far the most commonly used substance in Australia, with about 3/4 of people reporting that they'd used alcohol recently. And actually about 1 in 4 people had recently had a single occasion risk use. So that's using above the recommended levels, which can put you at immediate risk of harm. Next most common drug in Australia is tobacco smoking. And then the most common drug after that is cannabis, which is by far the most common illicit drug in Australia. It's followed by that with, there's a number of different illicit drugs that are used, and also pharmaceuticals, so people using prescription medication when it's not prescribed for them or at greater amounts. There is some good news with tobacco smoking. So the prevalence of tobacco use has dropped rather dramatically in recent decades. So in 1991, about 24% of people reported daily smoking, whereas in the 2019 survey, that was down to 11%. It's quite a big drop. There's actually, that seems to be largely in young people. So they're the ones that are kind of taking up tobacco less often. With people in their 40s and 50s, actually the most likely to smoke daily currently, which 20 years ago was actually more like people in their 20s. There is an increase in e-cigarettes, which you've probably heard a lot about. So there is some indication that maybe young people are taking up e-cigarettes rather than, tobacco smoking. It's a little bit too soon to kind of gauge that at the moment. And we know as well that quite a lot of people, even though they're smoking regularly, they still do want to or plan to quit. So about 7 in 10 smokers report that they do actually want to quit, although that also means that about 3 in 10 current smokers have no plans to quit. So that's something we'll keep in mind for the idea of brief intervention. Similarly, there's good news for alcohol. So many Australians are giving up alcohol. So there's a higher prevalence of abstainers now, so either people that used to drink and have stopped. And there's also less uptake of alcohol, again, particularly in young people. And young people are delaying the onset of drinking. So used to be average age around 14 for starting to drink. Now that's more like 16. So we're seeing people take it up much later. There is unfortunately still sort of a bunch of people that are using alcohol still at risky levels. Interestingly, again, still that seems to be mostly around the older adults. So older people still kind of maintaining those similar patterns of alcohol use, whereas young people are less likely to take it up, and those that do drink are not drinking as risky at such risky levels. Of course, there are still, a minority of young people that still do drink at those harmful levels, which again, I'll speak to later on. And also concerningly, of those people that do drink at the moment, about 1 in 10 are likely to meet criteria for alcohol dependence, or an alcohol use disorder. So that's still quite, considering the prevalence of 3/4 of people drinking, that and then 1 in 10 people that are drinking actually meet criteria for an alcohol use disorder. There is quite a large group of people that would benefit from help with their alcohol. Illicit drug use, it's a bit mixed. So a lot of the drug use has increased in recent years. So that's the case for cannabis, cocaine, ecstasy, hallucinogens, inhalants, and ketamine. But the use of painkillers and opioids for non-medical purposes has decreased a little, as well as those emerging psychoactive drugs. Also, methamphetamine use has stabilized. So there was a peak in 2001 where over 3% of people reported current methamphetamine use, whereas now it's just over 1% and it's been stable for a few years. The average age of people trying illicit drugs has increased, similar to alcohol. We know that with drug use, that the use of illicit drugs has actually continued to increase amongst older age groups as well, and that's largely driven by cannabis use. So as we can see, overall, there is a pattern for older people continuing to use alcohol and drugs, or even some people taking up alcohol and drugs, but still, a minority of young people as well that still have problematic substance use. In addition to the prevalence of alcohol and other drug use, as you'd be aware, there's also many harms associated with substance use. So alcohol and other drug use contributes to thousands of deaths, disease and injury, social and family disruption, workplace concerns, violence and crime. And it's estimated that alcohol and other drugs cost the Australian community over $23 billion per year. Good rationale to be doing more to reduce substance use. We know that excessive alcohol use is a major risk factor for morbidity and mortality. So both those short episodes of heavy drinking, so they can be a major cause of road and other accidents, domestic violence, public violence and crime, as well as long-term heavy drinking is a major risk factor for chronic disease. Tobacco smoking is particularly problematic. It's actually the single most preventable cause of ill health and death in Australia. It's a major risk factor for coronary heart disease, stroke, cancer, and more. In 2015, tobacco was responsible for over 9% of the total burden of disease and injury in Australia, and more than 1 in 10 deaths. So that's compared to about 4.5% for alcohol and 2.7% for illicit drug use. Tobacco use contributed to burden for 8 disease groups, including 41% of respiratory diseases, 22% of cancers, and 12% of cardiovascular diseases. Specifically, it's estimated that 78% of lung cancer disease burden and 72% of chronic obstructive pulmonary disease burden was attributable to tobacco. And while illicit drug use is less common, when people do use drugs, it can be associated with substantial harms, such as blood-borne viruses, malnutrition, co-occurring mental health problems, cognitive impairment, suicide, overdose, and more. And sadly, the average life expectancy is 20 to 30 years shorter among people with substance use disorders compared to those without such problems. So we really need to be doing more to tackle substance use, both in terms of treatment as well as prevention of substance use. So one option for intervention is brief intervention for substance use. So the World Health Organization defines brief intervention as practices that aim to identify a real or potential alcohol or other drug problem and motivate an individual to do something about it. So even though substance use disorders are quite prevalent, people often do not seek treatment for substance use disorders for a variety of reasons, including stigma and lack of opportunity. So it's an important idea to try to reach people when they are accessing services. So brief interventions can be a great option for that because it can be opportunistic, such as when people are presenting to, say, an emergency department or a GP practice for a physical health problem. A brief intervention could be undertaken. So brief means brief, they're typically only one-off session. It could be up to 4 sessions, but even so, they're very short duration. So it might only be 5 minutes long. Maximum, you'd be thinking 30 minutes. And they fall within the harm reduction paradigm. So it's not a treatment per se, in that, the aim is to, maintain abstinence. It's more starting off the conversation, giving people feedback, giving people some ideas about how to initiate change. Typically that's done with screening. So they would ask people questions about their drug and alcohol use, give them some kind of feedback about where they fit or compare to the general population or into, say, harm reduction quantities. So you might do something like the audit or the DUDIT, which are brief screeners. Then they can tell people if they're at risk of, say, hazardous drinking. They can also compare to similar rates in the population. So people can know that they're actually in the top 10% of drinking or something like that. There is good evidence for brief interventions, moderate quality evidence. However, it can be time limited, which makes sense in that they're more about starting off a conversation. It can be really helpful for then adding referral to the conversation. So you do the screening, the feedback, give people some initial ideas about how to start off, and then referral options that if they wanted to continue and get more substantial treatment, then they know where to access that. Also, evidence that brief interventions are more effective for those at risk of developing substance use disorders. For example, with kind of early problematic use, they're experiencing harms related to their use, but it's not at the level of a substance use disorder. Once you get to a level of substance use disorder, then more substantial treatment is typically required. So some common models of brief interventions, the experts, basically what I was referring to before. So you've got the screening. So say someone might come in to see the GP, they might mention, some physical health problems. The GP could screen their drug and alcohol use. They could let them know that they're, for example, drinking at risky levels, and then have give them an option for some referral to some treatment settings. That could be very brief. Frames is a little bit more involved. So you still do the feedback. So you'd assess someone and give them some personally relevant feedback. Then there's the acknowledgement that the person is responsible for their own behaviour, which is similar to a motivational interviewing type approach. Motivational interviewing is typically used within a brief intervention. So to let the person know that they can make their own choices, it might not be the right time, but they're also responsible for their own behaviour. Some advice, so that might be something like, your level of use can cause you health problems. A suitable or more a less risky level of use for you would be, say, to fit within the NHMRC alcohol guidelines, and they might outline those guidelines. Then a menu for change. So that's basically suggesting a few different types of strategies that people could try to start off their reduction of substance use. So that could be monitoring, so writing down how much they're using, when they're using, what seems to trigger their use. It could be identifying high-risk situations, which is often part of that monitoring. They might see that, okay, evenings after work are a big problem for them. So that's when I need to put in some strategies. Alternative activities can be helpful. For example, if they're bored, it could be in the evenings that they might plan social activities then, or do exercise at those times. Or it might be developing more support network. So potentially finding people within their network that could be supportive in this process, or potentially reaching out to find other support, such as a smart group or Alcoholics Anonymous or something like that. Always important for the healthcare provider to show empathy. So really showing that compassionate understanding from that person's point of view. They can understand, that their substance use has been helping them in many ways, and then it's really difficult to stop. But then adding in that self-efficacy, that you have confidence that they'll be able to tackle this, that there's lots of strategies that they can try, and there's many options for support along the way. Kind of generally what would be included in most brief interventions. I'll go through an example that we did in partnership. So Matilda Centre in partnership with the University of Newcastle. This is a brief intervention for methamphetamine use. This is kind of merging into brief therapy. So it is quite a lot longer than just doing the initial kind of screening and feedback, but it's still, about 4 brief sessions, but the person can do it online. So it's an internet-based brief early intervention for people using or thinking about using ice. that's the website if you want to check it out more. These slides were shared with me from the University of Newcastle team, so I'll thank them for the slides. So basically, the Crystal Clear program is based on the latest evidence drawn from research literature and clinical expertise on what works best to support people wanting to make changes or thinking about making changes to their drug use. When they were developing this program, the researchers spoke with people with a lived experience of using crystal methamphetamine before they developed the program. And they also used their stories in the modules and used their stories to assist them with the development of the program content. So that's the 4 main modules there. So what's in it for me is an overview of the program, weighing it all up, where people can look at sort of pros and cons of methamphetamine use and where they're at with their use. Where to from here when they're deciding what they want to do about their substance use, if anything, and then goal setting, where they can start planning out their treatment. Basically, Crystal Clear aims to help users to manage their methamphetamine use. It displays the impacts that ice is having on their life, as well as the physical and emotional effects, and is aiming to help people to change their lifestyle around drug use. As you can see, it has many of those aspects of the frame. So they're giving them specific information about their personal use, harms associated with their use. It supplies them with strategies that they can take up, but it's all very self-motivational. Its responsibility is theirs, and there's support if they need more help. It's really interactive. So in addition to the 4 main modules, there's some mini modules that they're welcome to access. So there's one on relapse prevention. So once someone's managed to reduce their use, how to kind of keep on track with that, managing change, dealing with stress, because that's going to be a common trigger for relapse, and communications. That's often something that people need to work on within their treatment. They also get a calendar, so they can use that to track their ice use as well as their moods and cravings, and that can help them identify patterns. So you can see in the graph as well, it has their sleeps and the problems that they're experiencing. So it's much easier when it's mapped out for people to see, like, oh, okay, you know, the ice use happens when I'm feeling this way and it causes these kind of problems and it impacts on my sleep, for example. It can be really helpful with the motivation, as well as, you know, seeing the ice use reduce, and then if that also helps their mood and helps their sleep and reduces other problems, that can be really helpful for self-efficacy and for maintaining motivation. The toolkit is a personalized information and resources page where users can learn more about the effects of ice, find support, and read about other people's stories as well. This is the Cracks in the Ice website, which you can find on the Matilda website. This is where you can access the Crystal Clear program, but it also has a range of other resources for community, family and friends, health workers, schools, Aboriginal and Torres Strait Islander people, brochures, etc. So you can access that for additional information about methamphetamine. And as I mentioned earlier, the Matilda Centre also has a range of resources as well. So this is resources for clinicians or healthcare professionals. There's the National Comorbidity Guidelines, which can help with managing co-occurring substance use and mental health problems, because we know they often go together, as well as information about other programs, webinars, brochures, etc. General resources for the public, so videos, e-health resources, booklets, fact sheets, as well as specific resources for schools, so online training, booklets, as well as the Positive Choices website. So you can, it's a portal for parents, teachers and students. So we'll cover things like evidence-based drug prevention programs, as well as have all sorts of information on drug use. this is not Matilda Centre. This is the Insight website, which I really love and has so many great resources. Particularly, I love these ones for brief interventions. So you can use them online, like just print them off online, or you can order kind of large brochures to get sent out to you. And this could be a really good one-off brief intervention to use with someone. So for example, this is the methamphetamine one. So you'll see kind of similarities with the cracks in the ice, but rather than being, say, 4 online programs, this is something that you could print out and use with someone. So it still goes through the background with facts about methamphetamine, asks the person about their own methamphetamine use, and then gives a bit of a reference point so people can see, oh, okay, I'm using a lot more than most people. Asked about the good things about using methamphetamine as well as the not so good. So obviously people are using drugs for a reason. There's things that help them or that are enjoyable, or at least initially there were. So it's really helpful to look through that, because they're also going to be things that you'd need to cover when you're trying to reduce your methamphetamine or other substance use. For example, if it's a way of managing emotions, then people will need to be finding other ways to deal with sadness or anxiety or stress, etc. And also having that written down, what are the not so good things about the methamphetamine use, because it can be very easy to forget that when you have a craving. You know, we get very short-term focused, just want to satisfy that craving, and all the problems can feel very distant. So actually having it written down right in front of you can be really helpful to think, oh yeah, that's right, it's impacting on my relationships, it's impacting on my health, it's impacting on my sleep, etc., etc. Really helpful to look at how much people are spending. Again, getting that down on paper and having it very clear how much people are spending on their drug of choice. The next part's about how worried people are about their ice use, but also how important it is to change. So that can be really interesting in terms of motivation as well. Someone might feel very, very worried about the drug use, but not feel like they can change. So you know there that you really need to work on that person's self-efficacy, look at strategies, help them feel more confident to be able to change their methamphetamine use. Vice versa, if you found someone wasn't that worried and if they wanted to, they could do it easy, then you probably be more looking at the problems around methamphetamine use. So it could be that they're not really experiencing many problems, or it could be that they're not acknowledging the negatives, they're really just focusing on the positives. So that would be, again, more of that motivational interviewing kind of idea of spending some more time exploring the methamphetamine use itself. Then you've got tips to stay safe. So this is where you get into sort of the advice and the strategies, and really within a harm minimization approach. Also looking at overdose, which is not necessarily as commonly known as it is for, say, opioids, that people can have methamphetamine overdoses as well, and what that looks like, what to do. Then looking at some of the practical things that people can do to cut back or quit. So again, increasing that self-efficacy, helping people feel confident that there's some things that they can try, and then really clarifying their plan, and having some links to other services or people that they can reach out to if they need. It's a really nice kind of overview of a brief intervention that you could use for methamphetamine. It's a similar one for alcohol. So I guess the only things are a little bit different. You're also educating people about standard drinks, which might not always be commonly known. For example, people might say they come home and have 2 glasses of wine, but you know, with a free pour, it could well be, you know, 4+ standard drinks. So just some education about how much people are actually using can be really useful. Also that comparison of their use versus the general population. People tend to compare themselves to people that they know. So if, say, you and your peers all drink a fair bit, that's normalized and it can maintain drinking at that level. And if you find out that actually you're in the top 5% and the majority of people do not drink that much, then it can get people thinking about, well, maybe their use is a little bit more problematic than they realized. And just giving them those risk categories can be really helpful as well. So, you know, a score on their audit of, say, 4 to 5 puts them at moderate risk of harm, 5+ at high risk of harm. But again, it goes through the spending, good bits, not good bits, confidence, how much they're worried about their drinking, some strategies, and then their planning. Actually, sorry, I should just say here as well that there's also some harm minimization about alcohol withdrawal, because if people are drinking at a high level and then stop suddenly, it can be dangerous. They could have seizures. So it's really important that people reduce alcohol use slowly if they're drinking at high levels, if they're quite dependent on alcohol, and be best to do it in combination with a GP. This is the cannabis one. So again, it's the facts, comparing their use to other people, harms about use, good things, not so good things, some tips, and a plan. A little bit about what cannabis withdrawal looks like. And benzodiazepines, again, similar with some facts, some harms, good things, not so good things, their severity of dependence. So that's another good scale that you can use as a screener. So if you've asked people what drugs they're using and they come up and say, oh, I'm quite regularly using Valium, for example, then you can go through this very brief measure called the severity of dependence scale, and it can give you an idea of how problematic their use is in terms of how much they rely on that drug, if they're tolerant to its effects, if they experience withdrawal, if they have tried to quit and they can't. It gives you a good indication that their dependence is quite high. Similar to that, if someone is quite dependent on benzodiazepines and quits suddenly, they can also experience significant withdrawal problems such as seizures. So again, that's important to do it slowly and preferably in a detox or in, as an outpatient with GP supervision to really withdraw from that drug slowly and carefully. And then the final one is for opioids. So again, goes through all the different types of opioids. So people don't always necessarily realize that if they're, say, using codeine, that it's an opioid. So it goes through the different types, how much they're using, good things, bad things, how much they're spending, etc. Again, some tips to stay safe, what to do in the if there was an overdose, their plan for quitting. Yeah, I really like those resources, and the Insight website in general is great for lots of drug and alcohol information and resources. So that's promising for, I guess, adult population, that there's pretty good evidence for brief interventions for at least starting off that process. Some people would need more help and be referred into other services, but it's a really good way of, I guess, picking up people that might not even have really been thinking about their drug or alcohol use or really planning to quit. Can just start them sort of thinking about that and making some plans to try to reduce. However, if we wanted to get in earlier, we'd probably need to be focusing more on adolescents, so that, 15 to 24 year age group. It's also when substance use tends to start, during the teens and early 20s, and also where the peak impact of harms are occurring. So even though people are delaying their drug and alcohol use, it's still when it really starts, and there can be lots of risky ways of using. And it actually does contribute to the top causes of death for young Australians. So suicide, road accidents, accidental poisoning, and assault. Unfortunately, there's not much research on brief interventions for adolescents in primary care. There's also some complications with, parents and privacy. It's a little bit complicated. Schools could be a really good avenue for doing brief interventions, but a recent-ish review on brief interventions in schools didn't find much evidence. And it's a little bit tricky to do within schools as well, in that a lot of the time it tends to be universal kind of curriculum based, whereas a lot of people we're not necessarily going to have problems. It does actually make sense to target the ones that are more problematic substance use or at risk of more problematic use. And that's where there is good evidence occurring, or increasing evidence, is in that selective intervention idea, or selective prevention. So that's when we target people that are at greater risk of substance use problems, and we target that risk factor so that we try to prevent people either starting substance use or having a less problematic kind of relationship with substance use. So that's where the personality targeted interventions come in that I'm working on at the Matilda Centre. So personality is basically people's tendencies to act, think and feel in particular and consistent ways. They result from a combination of genetic and environmental influences. And our personality really impacts on the way we experience the world, the way we interpret the world, the way we respond to the world around us, and our interactions with others, as well as our perceptions about ourselves. So really do, our personality impacts on such a broad array of our lives. That's a really helpful risk factor to target. And also we can target personality before substance use or other problems occur. Because it predicts a range of alcohol and drug issues, we don't have to wait until problematic substance use is occurring before we commence, say, a brief intervention. We can have a pretty good guess at who is going to be likely to have more problematic substance use and target those people early. And also personality can predict a range of other emotional and behavioral problems. So we can also be preventing, say, depressive anxiety problems, risk-taking and other antisocial behavior. So we can work on coping skills before the onset of problems. And it also gives us some detailed information. So knowing about different personality types, we can actually get a clear idea of why people are using certain substances and also what kind of pattern they might use. I'll go into that more in a moment. So the personally targeted prevention program that I work on is called Preventure. That was developed by Professor Conrad at the University of Montreal. And it basically targets 4 personality traits that have been shown to be associated with an increased risk of adolescent substance misuse, as well as common emotional and behavioral problems. The first one is negative thinking. So that's low mood and having negative beliefs about yourself, other people, and the future. Then there's anxiety sensitivity. So that's a fear of anxiety-related physical sensations, such as if you start to feel anxious, and then your heart rate increases and you can feel really anxious about your heart rate. Am I going to collapse? Am I going to have a heart attack, for example? Impulsivity, so really jumping in without thinking, really limited self-control. And sensation seeking, so people that are really prone to boredom, that really have that elevated need for fun, excitement, and similarly for that reason can be high in risk taking. So here you can see some specific patterns between these personality types and alcohol use. So negative thinking is actually associated with earlier onset drinking. Heavy consumption of alcohol once people do start drinking, and greater drinking to cope. So it's really that kind of escape from painful feelings, numbing oneself out. Anxiety sensitivity, on the other hand, is actually associated with later onset drinking. So people tend to be anxious about kind of losing control and would be more likely to start later. But say when alcohol is legal, when they're 18 and they do say come across alcohol, they can find that it really reduces their anxiety and then can be really reinforcing. So kind of rely on that for the anxiety reducing properties, which makes them at greater risk of problematic drinking. Impulsivity and sensation seeking are both associated with earlier onset drinking, as with negative thinking. Sensation seeking is kind of more of a binge drinking flavor. They're drinking more for enhancement effects because it's fun, it's exciting, and they can get into risky situations because of that and can have harms related to the alcohol use. Impulsivity is broadly problematic drinking, and they basically drink because it's there, they can't not. And these are also the links between these personality traits and other emotional and behavioral problems. So as you'd expect, negative thinking is more linked to depression, whereas anxiety is sensitivity to panic-related disorders, but both are broadly linked to emotional problems as measured by the Strengths and Difficulties questionnaire. They're more kind of internalizing personality traits with internalizing problems. Then sensation seeking, impulsivity are more externalizing personality types and also have more externalizing problems, so antisocial and risk-taking behaviors. So it's nice that we can target substance use, but we're also targeting those common co-occurring emotional and behavioral problems with these personality types. So basically, Preventure is a brief intervention. It only has 2 workshops, but they are 90 minutes. So this is a little different to that very brief, kind of one-off 5-10 minutes type brief intervention. It's more of a kind of a brief therapeutic prevention program. Basically, you go in to say the year group and you screen the entire year with the personality screener, which is called the Substance Use Risk Profile Scale. You see who screens in as higher than average on one of those 4 personality risk factors. It's usually around 10% per personality type, so about 40% of the year would probably screen into one of them. It generally would be year 8 or 9 students, so you're kind of aiming to come in just before most people are starting to use substances. And it's based on both principles of motivational interviewing and cognitive behavioral therapy. And the main aim of Preventure is to help students to understand their personality and develop healthy ways of coping with their personality to prevent alcohol use and other internalizing or externalizing problems. So there's actually very little discussion of drug and alcohol use itself, and it's prevention. So we're assuming most people haven't actually started drug or alcohol use yet. It's more focused on their personality, to getting to understand themselves, their ways of coping, and then trying to develop healthier ways of coping with the aim that then they would not potentially be relying on alcohol or other drugs as a way of coping. So the 2 90-minute workshops are generally delivered a week or 2 apart so that there's time to practice in between, and would be in small groups of around 4 to 10 students. They're delivered by a trained facilitator and a co-facilitator. And basically, the interventions include initial goal setting. They look at their pros and cons of choices and behaviors. That's a very motivational interviewing focus. Then they go more into a CBT focus, where they're understanding the links between their thoughts, their physical sensations, and their actions. And they get more specifically into identifying and challenging their personality-specific cognitive distortions. So the unhelpful ways that they tend to think and respond that are related to their personality type, and how they can actually think in more realistic or more helpful ways so that they feel better and make choices that they want to make that will get them closer to their goals that they want to achieve. There have been many randomized controlled trials done on Preventure around the world, so mostly North America, but also Europe, and our Australian trial is there with the star against it. Kind of popping them all together, Preventure reduces alcohol use, binge drinking, and drinking-related harms by about 30 to 50%. So it's about half as much uptake of, say, drinking in Preventure students and control students in those trials. And this is just a little bit more detail on our randomized control trial that we did on Preventure. So as I mentioned, Preventure is designed in Canada and was used a lot in the UK. And then we brought it to Australia. We first of all adapted it for Australian young people through focus groups so that we could use stories from Australian young people, change the names and the images so that it was more accessible and relevant for Australian students. And there was a randomized controlled trial, 7 in control, where they just did their normal PE, health education, drug and alcohol, social emotional learning. And then 7 to Preventure. We screened everyone in the SERPs. Then the control students did their usual PE, and then the Preventure students that screened in were invited to do the personality workshop relevant to them, completely voluntary. So over 3 years, we found that relative to students in the control schools, students in the Preventure schools reported significantly less alcohol use, including less uptake of alcohol, less binge drinking, and less alcohol-related harms. And we also found that students in Preventure schools reported significantly less emotional and behavioural issues, including less psychological distress on the K6, less anxiety symptoms and depressive symptoms on the BSI, and less conduct problems and hyperactivity on the SDQ, which we're pretty happy with 2 90-minute sessions to find effects 3 years later. We're also happy that the students enjoyed the program. So for example, students reported things like finding it helpful to reflect on their personality and on their goals, to understand, say, what anxiety is, how to manage their feelings, and to identify and challenge thoughts. However, not everyone liked it, and they didn't like everything about it. Some young people found it uncomfortable talking in front of others about their personal stories, even though it's voluntary. Obviously, it could still be confronting for some people. Some people didn't like it being brief, wanted more time. Other people wanted less time. Some students were annoyed that it took up lesson time, wanted to do it at lunch. Some really loved that it took up lesson time. And they all really liked the lollies that we gave them as well. And excitingly, we're also been analysing the longer term follow-up. So there's an extension where we followed them up at 5.5 years, so just before they were 18, so to see before legal alcohol use. Then at 7 years, so once alcohol was legal, to see if there were any sustained effects. It does look very promising, but you'll have to watch this space for the long-term follow-up of Preventure. We're also running training in the Preventure program. So Professor Conrad came to Australia and trained us as facilitators. So a bunch of us went into schools and ran the program as research psychologists. But it's not always going to be possible for schools or other services to bring external people in. So also training teachers, counsellors, youth workers, drug and alcohol counsellors, etc., in Preventure, so that people can run it themselves. If you're interested in doing the training, you can check out the Positive Choices website and get more information there. We run the workshops pretty regularly. And it also has other information about Preventure on that website. Or you're also welcome to email me if you have any questions about Preventure or anything covered in the presentation or about the Matilda Centre in general. And thank you so much for your time.
No worries. Thanks, Erin. That was really great.
Pleasure.
When you showed the the household survey results, I was just thinking about how fascinating the next one will be to see the impacts of COVID-19 and the disruptions in logistics and shipping and all that.
So true.
Do you know when it's due? I should have Googled that, but they're every 5 years or?
Yeah, or every 3.
Yeah, right.
But that's this year. Although I think it's always maybe delayed. It'll probably come out next year. I do know some people at the Matilda Centre and other places have been looking at impacts of COVID on substance use. And I think it's varied. So some people increased their alcohol use, some people decreased, some drugs were more available, some people couldn't get, so it's a pretty mixed bag as far as I know. But yeah, it'll be interesting to see that broader detail.
Yeah, absolutely. So we have some questions. Jeremy's asked if there's a way that people can use the Crystal Clear program anonymously because it appears you need to log in via email.
Ooh, good question. I don't work on that program directly, so feel free to email me and I'll forward it on to them to ask. But yeah, maybe you can just actually I won't because I don't know the answer. I'll feel free to email me and I can forward it on to them and see what you think, what they think. Sorry, but yeah, I'd hope so.
Yeah, it might be tricky because they might need an email to log in to access their stats and stuff, but maybe it doesn't need to be maybe you can set up a burner email for it or something.
Yeah, yes, I was going to say, but I didn't know. So yeah.
Yeah, that's
what he said.
Yeah, complete conjecture from me though. Tracy's asked if there's any related to polysubstance use. I assume she's talking about the resources, the brief intervention, the colourful ones that you were showing us from Insight, the Queensland ones.
No, unfortunately, that was all I found. I pulled all the ones off that were there. So I guess you could speak to and say that polydrug use is very common, and then maybe ask them for the drug that's concerning them the most at the moment and start with that one, because there'd be a lot of transfer of skills. And then potentially if they had, okay, I've got a couple, then, it'd still be really worthwhile to go through both. And it's even some of the evidence was saying that one-off brief intervention might not be ideal. It might be best to follow people up anyway. So potentially if there is polydrug use, you could do, pick one, do that, and then, in a month or two, do a second drug and then do a third drug, so that it's nice reinforcement of the principles, but you're also getting some time to talk about the specific drugs as well.
And yeah, it might be too much. If a person's thinking about ceasing their use, it might of 3 drugs, it might be too much to think about quitting all of them at the same time, or overwhelming.
So true. Yeah.
Thanks, Tracy. So Dimity has asked, do any of the brief interventions for AOD include consideration of the risk of drug or drink driving, if that is also part of the user's behaviour?
Yes, and I like that the brief interventions from the Insight program tended to have that on there. So looking at harms including drink driving or drug driving, it'd be definitely something that you'd be wanting to cover in your brief intervention. So, for example, if someone said that they were using a drug daily and they also had to drive to work daily, or say, drove their kids to school daily, you'd definitely be following up and checking, if they were using just before drinking at driving, but also let them know that even if they don't feel intoxicated, if they were pulled over from the police, that if something's in their system, it could be, days that it's still going to be picked up. So it's really important to have that conversation, definitely.
Thank you. Richard said, great input and talk. Are there any cultural, language, specific group realities such as Aboriginal and Torres Strait Islander, refugees, etc.? I assume talking about, again, those resources. And then a second question is there an age cutoff for prevention?
Oh, good. Thank you. There's good evidence for brief interventions across different cultural groups in terms of the research base. In terms of specific resources on that website, not that I came across, that doesn't mean that there weren't, but Insight in general has lots of good stuff on Aboriginal and Torres Strait Islander populations. So you could check if there is something there. But yeah, in terms of the research base, it's pretty broad. Prevention specifically, even though it's designed as a prevention program, so you're aiming to kind of get in before most substance use would kind of, before that kind of mid-teens level, and the booklets, they have a lot of stories, so they're kind of aimed around about a 14, 15-year-old that they're relevant. There's no age cutoff per se in terms of if you were to, the developers are happy for people to get in touch with them and adapt the materials. So it would just be more adapting the stories and the context so that it feels relevant, because it's still found to be effective for people that are already using drugs or alcohol. So it's in that way, it would be more of that kind of brief intervention, early intervention kind of example rather than a prevention program. They are doing some studies in Canada looking at prevention university students, so that would be more appropriate for older people, but again, it would be for Canada. But and I know in their early trials, they actually used it in drug programs, so drug treatment programs, rehabilitation services, and found it effective as well. So, sorry, long-winded. Basically, you can use it with adults, but not in its current format, because the relevance of the program is a huge aspect of it. They really want it to be relevant to your cultural group, your age, your geographic location. So you can speak to them about adapting it for your people.
Great, thank you. Harriet says, great, program sounds great. Could the Prevention one, could this program be delivered one-on-one rather than in a group setting?
Yes, definitely. So there's a lot of benefits of the group. For example, finding that, you know, you're similar to other people and hearing other people's ways of coping. But it can sometimes be more practical to do it one-on-one. For example, if you have a small group, so you've got a small year, or you're doing it in, say, a youth service, it'd be quite awkward to have it with 2 or 3. It'd actually be better to do it one-on-one. You want to have like 4 or 5 max. I mean, 4 or 5 minimum to do it. Also, if there's someone that has, say, learning difficulties, it's recommended to break it down and maybe do 4-hour sessions or something like that one-on-one. You can also do it one-on-one as a booster. So, for example, you could do it with the group, and then maybe 6 months later, you sit down and do it one-on-one with some of the students that were still struggling.
Yeah, great. Thank you. Laura's asked the prevention, or says the prevention program is really interesting. Is the substance use risk profile scale accessible in the public domain?
No, it's quite specifically tied to the prevention program. There's also some complexity around it in terms of how it's presented. So the training goes through lots of detail about how to talk about the personality risk factors and how to talk about the screener. For example, it's not called the CERPs for the schools or for the students, because it can be confronting to think that, you know, your substance use risk profile, and so it's usually just called a personality screener. You have to do the prevention training to access it so that you can introduce it properly and use it properly. And yes, there's the Woikik paper talks about the substance use risk profile scale and how it was developed and the psychometrics of it, but it doesn't actually have the scale itself, if that makes sense.
Great, thank you. And Bill has asked, any plans to use prevention program in Victorian high schools?
We'd love to. The moment, we've done mostly training in person, so it's mostly been New South Wales and Queensland. Actually, some people came over from Western Australia. We're starting to move to some more online training as well, so more people can access the training. And also, hopefully, if COVID settles, then we're able to do more traveling as well. So if it's just 1 or 2 people that want to come do the training, you know, they might want to come to Matilda Centre or somewhere in New South Wales. But if there's a bunch of people, we can actually fly to you, so we could come do it in Victoria.
Sounds great. All right, that's all the questions, and that puts us at exactly on time. So thanks very much, everyone. Oh, okay, we've got another one. Yep. Any idea of using this amongst neurodiverse community, or do you have a program for this special cohort?
I have checked with the developer about that. They said at this point they would recommend it doing it one-on-one and more sessions. They are doing a lot of work in Canada looking at the benefits of Preventure cognitively. And I know Professor Conrad has a strong interest in neurological effects. So I'd say it's something that she's interested in, but at this point, there's no specific program available in terms of Preventure. And in terms of neurodiverse substance use programs in general, not that I have seen, but again, I could just not have seen it. So feel free to email me and I can have a bit more of a look around for you and see if there's anything around.
Great, thank you. And if you have any further questions, feel free to email me or Erin, because her email's right there. Yeah, that's actually easier. Just email Erin. Thanks everyone for joining us. And thank you very much to Erin for her very interesting and presentation. I'll be in touch this week sometime, hopefully, with a copy of the slide pack and information about where you can access the recording of this webinar. That's it. Thanks again, Erin. Thanks everyone for attending.
Thanks everyone. Thanks, James.
Bye.
Bye.